I would like to thank all of the speakers and encourage questions from the audience about the presentations this morning, so it's open for fruitful and lively discussion. Yes, please.
Ed Saltzman from Tufts and the American Society for Nutrition. Thank you for your excellent illustrations of how One Health really could work. Another unintended consequence of globalization, as I'm sure you're aware, has been the rise in overnutrition as well as undernutrition in the developing world. So I'm curious if overnutrition and related diseases such as type 2 diabetes are on the One Health radar screen, and if you think One Health offers a potential pathway to at least amelioration.
Looks like I'm elected. You know, I think you've raised a good point, and we often think about this conundrum between the areas of the world and the people in the world who suffer the consequences of plenty compared to the people in the world, the roughly billion people in the world who go to bed hungry every night. You know, I think there is a relationship there. It's a complex one. We know that we waste a tremendous amount of the food that is produced every year. That's a big part of the food security issue that I don't think is receiving very much attention. We also know that in many of the transitional countries in the world, there is a shift in human choice and perception of what is the appropriate food that establishes a country as wealthy, if you will. That shift towards an increased desire for animal protein comes at the cost of potentially diverting grains to feed and raise livestock that could otherwise be fed, at least in some cases, directly to human beings. And so then what does that do in terms of driving the kinds of foods that are consumed by people who don't have access to healthy foods? And so I'm sorry, it's not a simple answer, and I'm not trying to be circumspect, but it's a complex web of things. But yes, I think you're absolutely right that it all does relate to this relationship between humans and animals and the lands that we use to grow crops and to raise livestock.
There is a direct relationship for agricultural productivity and the El Nino events. That's been shown very clearly in South America, to the point where actually predicting the El Nino allows the farmers to change their crops that they will plant. I think we already see what's happening in the west coast of the United States and the prediction for a continued drought. So this food surplus may be something that we probably enjoy now, but we may not always. So that's another consideration of climate effect.
Yes, Jan?
Thanks for this very comprehensive approach. I think it gives really inspiration to put into perspective what we do in the daily practice here. Nevertheless, there are a lot of links, and I thank Laura for drawing our attention on the issue of brain drain and the maldistribution of human resources. 1 out of 4 medical doctors every year leaves South Africa for a Western country. There are more Botswana doctors outside of Botswana than inside of Botswana. So I think there's really a problem, and we still, as Western countries, sometimes use it as a strategy. It's cheaper to have a nurse trained in India in your health system than to train the nurse yourself. So I think we should really have a system of reimbursement so that every Western country that integrates a healthcare provider in his health system should reimburse the full cost of the training of that professional in the receiving country towards the country where the person comes from. I think that could be a first start to make it more equitable. And of course, we were all shocked when we read in the 28th February issue in the Lancet that Uganda government allowed 300 Ugandan doctors to be sent to Tobago and Trinidad, a country that has 10 times the number of doctors than Uganda itself, in exchange of oil experts that will help the regime in Uganda to exploit the new oil reserves there. So it's the new slavery. We send out doctors in order to have oil And I think that this is it's really something we
tragic.
should reflect on fundamentally.
Right. Yes.
Sorry, I'm Harrison Spencer. I'm President and CEO of the Association of Schools and Programs of Public Health.
Yeah.
I'm Harrison Spencer. I'm a President and CEO of the Association of Schools and Programs of Public Health. At the planning meeting, I feel compelled to point out, we've just gone through a major process of looking at our curriculum called Framing the Future. And we started with town hall meetings. We've engaged employers, and we've had a 3-year process. And the result, including population health, MPH, DRPH, it's a whole radical restructuring, and it's on our website, asppph.org. I feel compelled to say that because I don't think exactly the curriculum that was presented is actually even what we're talking about now. The main point, though, for me is that why look only at public health? I said the other day that I think interprofessional education is actually a barometer for a hunger across many of us working in the health professions that something's wrong with the education. There's something wrong with the system too. And I think they're very likely, as we have with interprofessional education, that we ought to be focusing on a series of competencies that cuts across all health professionals. And that's why I respond so strongly against picking public health as the one to actually focus on. I would believe, quite frankly, hopefully we are very important for it. But lots of others, the medical school curriculum, nursing curriculum, physician's assistants, I don't care, you name it. And I would love to see us begin to move to sort of say at least part of the curriculum ought to be a constant across all health professions. Thanks.
Yes, I think that you point out a very important issue, and it wasn't meant in terms of this panel discussion to focus entirely on public health. And I think is exactly what you're saying. One Health concept is across discipline. It's not relegated to public health, physicians training, nursing training, but it's a composite of interdisciplinary activity. So again, I would like to emphasize that and point to the power of that cross-training and what the One Health theme is trying to promote. Yes.
I'd like to comment to that point. I was asked to form and chair for the American Meteorological Association or Society, a board on environment and health. And so I think that this is happening in other disciplines, the understanding that there's a very powerful interaction. So I would say that it would be very good if the schools of public health could connect across the non-traditional biological medical disciplines, and I hope you're doing that because that would be terrific, with the atmospheric and ocean sciences, the ecological sciences, and so forth.
May I just reply real quickly? Part of this Framing the Future is something called Population Health in All Professions. And we pulled together the clinical side, which mainly through my IPEC colleagues, but also non-clinic, law, business, architecture, and environmental health, and others. And that's the point. You're exactly right. And we are the bridge, hopefully, between the health profession and others. But, you know, the process of town halls and empty room approach where people begin to say, okay, let's put everything aside and let's look at what we think a curriculum ought to look like in the 21st century. And my bet is there's a core series of competencies that, and ones you're talking about, that are going to be very applicable in the world we live in the 21st century going forward, that are going to cut across all health professions. That's really the point I'm making, and you're absolutely right.
I would just like to thank you for your comment. Before the 20th century, there was actually quite a bit of integration and overlap between medicine, veterinary medicine, public health. They were all integrated and they were all working together. But as the 20th century evolved and the increasing specialization, you know, everybody went their separate ways. The establishment of schools of public health, for better or worse, essentially divorced medicine from public health. And they've essentially eliminated that from their curriculum, becoming increasingly specialized in teaching just organ systems rather than looking at the whole milieu of, you know, human society. So I think we have a lot to try to reintegrate that, to develop a broad-based curriculum for all the health professions, but it's going to have to, involve a substantial rechanging of how it's being taught. And it's very hard to undo what a whole century of, established systems have become. So I agree with you. And the only reason I chose public health is because it's much closer to implementing One Health than, say, medicine, which is very specialized in what it teaches its students.
So with that thought in mind, I'm going to ask my colleagues from the AAVMC to talk about this whole concept of One Health and their new initiative, the One Health Scholars. So Andy, would you say a few words, please?
Yes, thank you. My name's Andy McCabe. I'm the Executive Director of the Association of American Veterinary Medical Colleges. And we were just invited by the Healthy People Curriculum Task Force to join with them in an effort to bring One Health into the curriculum across the health professions. So the Healthy People Curriculum Task Force was convened by the Association for Prevention, Teaching, and Research, APTR, which is generally represents faculty in medical colleges and other health professions that teach preventive medicine. And the initiative that we've started is a case study method of instruction where we're inviting faculty members from across all of the health professions to develop case studies in One Health. So Chris Olson in his presentation talked a lot about the types of elements that are there, and Laura in her presentation also mentioned, some of the topics that would be there. So we have a call for proposals that we just issued about 2 weeks ago, and we'll be glad to forward that to the IOM staff here so that they can in turn forward that to the rest of the group. We invite broad participation from across the health professions in this effort, but we think the case study method is a good way to bring these principles into the curriculum.
Thank you, Andy. And I would like to comment on one of the possible case studies. In my discussion yesterday with Dr. Cox, I'm aware of the human-animal bond that is being utilized so effectively in the VA hospital system for veterans returning from overseas assignments and post-traumatic syndrome, and how important this whole concept, and I think it's a manifestation of the One Health concept, and certainly is very successful in the psychological well-being of these returning veterans in that close association. So that's another example, I believe, that would be very powerful One Health example about the close connection between human and animal health. So we have time for a couple more questions. I think Dr. Tlaib had a question.
Thank you for the excellent presentations. I think it's clear when we think about health professions education programs generally need to be measured by more than just education outcomes, and even the health outcomes are broad in terms of health of the environment, health of the community, health of the individual, and even financial responsibility. Education programs need to be measured by health, education, and financial metrics. And I come back to thinking about what Malcolm spoke about earlier, that it's disruptive change. It's not tinkering change that's needed. So if I think about what's needed to engage disruptive change, what are the levers? You can affect leadership, you can affect finances, you can affect policy and grassroots. And I want to comment on two in particular, the money and the leaders. So how do we affect the flow of money to affect this broader conversation? And while there might be a fixed amount of money in the traditional flow of money and the traditional flow of funding through health professions education, I think there are opportunities for other innovative areas of funding. I'm going to connect back to this in a moment, but at the last meeting on women's empowerment in March, we heard from impact investors. And there was a lady who spoke, she was an impact investor, and they had done a survey of health and where could they invest, and health workforce wasn't on her list. And I think I suspect the reason why health workforce was not on her list is because the metrics are not clear for impact investors. It's such a long-term trajectory to measure these outcomes. How do we engage an impact investor? We need some surrogate metrics. And just like an accreditation of a health hospital, there's the JCI accreditation, but now there's sort of these interim metrics for accreditation, and we need metrics to define success for health professions education that include these broader competencies. So I would propose to this group that we think about what are those metrics and how can we move this agenda forward by creating some concrete metrics. And the second comment I want to make is on leadership, because you talked about that, Laura. And I think it's an important lever in a system that if you want to drive disruptive change, you need leaders. So do we have an adequate pipeline for leaders who think broadly this way? Do we have clear competencies of leadership in health professions education? And a month ago, I was with Nelson Swankamba, who's also a forum member in Uganda, and we had this exact conversation that these competencies are not clear, whether it's in Africa or whether it's in the US. So can we convene that conversation on what is leadership that incorporates these different aspects?
Point well taken. Thank you. Elizabeth, I think you had a question.
Yeah, a comment, but a question for One Health. First of all, thank you so much. Excellent presentation. It's very important that we have the larger view and realize that everything is interconnected. So WHO, as you may know, came out with a statement that in 2020, throughout the entire world, about 1 in 2 persons will have cancer. And that this tremendous increase is actually due to the increases in all the environmental toxins, chemicals, electromagnetic fields as well. And clearly all those things are affecting climate change. So it seems to me, as we look at the issue of interprofessional education and all of healthcare providers, students, faculty, and practitioners, because patients are coming in with many of the ailments that are caused by these enormous amounts of chemicals. In the U.S. alone, we're exposed to over 80,000 chemicals, not including all the herbicides and pesticides. Like, how many of you know that Tide has no recognized carcinogens in it, and yet we're still allowing it to be used as a cleaning product? So while I think having the larger view is so crucial in the effect on the environment and climate change, I wondered how much emphasis you're tending to give to how these environmental toxins are so directly not only affecting all of our health, but all species health. I mean, we're just seeing that everywhere now. And it seems as though if we want our particular species and many species to survive, it does seem to be an issue that's very related to politics and costs that we need to address worldwide.
I think you raise an extremely important point. And I think, fortunately, with the tools, the computational tools that we now have, you're essentially addressing an aspect of what everybody calls colloquially big data. The way to analyze that kind of information is to accumulate it and to do the kind of analysis that allows conclusions to be made that can be verifiable. So I think we are capable of doing that, and I personally am delighted to see so many people in this room interested in One Health. I think that's really a 21st century conundrum and challenge.
So we have time for one question. Did I have yes, from
Yeah, I was
I'm sorry, Laura.
I was just going to say, respond quickly. There is no CDC for animals. There is no CDC for the environment. So in terms of monitoring it, there's no one entity that's providing that kind of data that we need to monitor not only wildlife, but the companion animals that share our homes and get exposed, or the environment. So that's a big oversight.
Right. So one last question, Lena. Table 7, the provocative and engaged table.
Yes. Well, so I'm from the National Hispanic Medical Association, and just taking an overall question here, looking at culture and lens, the cultural lens, let's say. We talked about global health and having our students go to countries like Ecuador and Latin America, for example, and we heard from Brazil yesterday. But I wanted to know, what do you think about the concept that we do need leaders from this country who are Hispanic, who can not only be a part of a program that's an immersion in another country, but that perhaps we bring others to this country and connect. And I'm thinking in terms of the Hispanic population in this country is so much a fabric of the country that people don't realize how much we need to build that into the global lens too.
Yeah.
Absolutely.
I really appreciate the fact that you raised that. I mean, I think what you're speaking to is that global continuum, and it's very important. In fact, there was an entire half-day session at the Consortium for Universities and Global Health meeting a couple of weeks ago in Boston, making exactly the part of the case that you're presenting. You know, just a couple of really quick thoughts. First of all, we talk about global health. If you go to Bangladesh and ask a healthcare provider whether what they do is global health, well, of course it's not global health. It's only global to us, right? And so I think that's one thing we have to keep in mind. We also, as you've pointed out, have to recognize and value the importance of not simply us going there, but others coming here, because we have more to learn from others, and we got a great flavor of that yesterday from Professor Campos. I'll give you one really quick example. We just brought several women from a village that we work in Ecuador who are indigenous women to Wisconsin to spend a week, and part of what we did is we brought them together with some of our Native American women in northern Wisconsin, and it was an absolutely fascinating opportunity to see two clearly related indigenous peoples sharing and recognizing, you know, how much they have in common and how much they share the same issues. So you're absolutely right.
Can I just make a quick comment? The Pan American Health Organization predates the WHO. It's the only one of the WHO regions that has its own constitution, and all of the leaders from all of the Americas come together to set policy and priorities. And I think it could serve as an important model for the rest of the World Health Organization regions to perhaps, you know, emulate them and establish their own constitution and meet regularly so that they, you know, the regional leaders know what's important for their region, not Geneva. And I think the people in the Americas, PAHO, could really set an example for how global health should be done.
All right, with that, I want to thank all the panel members for the exciting presentation and the lively discussion. So we'll move on to the next session.
Thank you. That was wonderful. We started yesterday thinking about, we had a presentation on one country's approach to envisioning the future of health profession education. Then we went through a series of fairly granular exemplars of how things have been being done at individual schools, universities, or across disciplines. And now we want to, we took this morning and looked at the One Health initiative, taking us back up again at a global perspective. But now we are going to assign the task of taking all this information and really addressing the three key purposes of this workshop. And so we're going to split into three groups to address three questions that were the genesis of this workshop. So we're going to ask for table 6 and 7. You're going to be assigned the first breakout question, which is what are the implications that shifts in health policy and the healthcare industry will have on health professional education, workforce learning. And that group is going to be facilitated by Thomas Clausen. In the center group here, 4 and 5, tables 4 and 5, will go to room 207 to address the question, what roles do the public and private sectors have in facilitating effective knowledge transfer with improved quality and efficiency? And that will be facilitated by Timmy Barwick. And then question number 3, those will be for participants on table 1, 2, and 3, will be in room 101. And that question is, what opportunities are available for building a global health workforce that understands the role of culture and health literacy in perceptions and approaches to health and disease, facilitated by Andrew Pleasant. Now, our guests who are sitting along the wall can join whichever room you would like to go to, room 105, 207, or 101. In this room, we will be doing webcasts, and members of the Global Forum will be presenting from here to our webcast presenters. So anyone who's presenting as part of that webcast needs to stay in this room. And I am going to ask, we did run a little bit long just to finish up the conversation on this last panel discussion, but if we could promptly then go to our rooms, and we'll get started. We'll then come back, do a group report, and listen to our final summative speaker. So thank you, and we'll go ahead and get started.